Hello everyone, and welcome back to Health Code Blueprint. Today we're moving into ICD-10-CM in clinical practice, focusing on ophthalmology and circulatory system scenarios. We'll take real clinical documentation and walk through how to translate it into accurate, guideline-driven codes. Before we begin, here's a quick reminder. This presentation is intended for educational purposes only. It does not constitute legal, compliance, or coding advice. Always follow official ICD-10-CM guidelines and your organization's policies when assigning codes. Alright, let's jump in. When we code, we're not just typing numbers into a system, we're translating a patient's story into a language the entire healthcare world understands. And to do that accurately, we have to pay attention to all the little details that can change a code. We look at things like whether the condition affects the left eye, the right eye, or both. We look at staging, is it mild, moderate, or severe? We look at causality, what's causing what? Is the condition acute, chronic, or somewhere in between? Are we dealing with a combination code that captures multiple elements at once? And how do all these conditions interact with each other? At the end of the day, the golden rule is simple: documentation drives the code. We don't try to make the documentation fit the guideline, we apply the guideline to what the provider actually wrote. That's how we keep the story accurate. Let's start with a classic ophthalmology challenge, laterality. In this scenario, the patient has glaucoma in both eyes, but the type and stage are different. The right eye has acute narrow-angle glaucoma, sudden onset, pressure spike. The left eye has primary open-angle glaucoma, moderate stage, a chronic, progressive condition. Because the type and stage differ, we cannot use a bilateral code. The guideline is very clear: if the eyes are not identical in type and stage, code each eye separately. So we assign H40.211 for the right eye and H40.1122 for the left eye. This ensures the record reflects the true clinical picture. Now let's look at disease progression. The patient is admitted with primary open-angle glaucoma in the right eye. At admission, it's documented as mild. But during the stay, the provider documents that the condition has progressed to moderate. Here's the rule: we code the destination, not the departure. In other words, we code the highest stage documented during the encounter. So even though the patient arrived with mild glaucoma, we assign the code for moderate stage, H40.1112. This captures the most clinically significant status of the condition. This scenario is all about incomplete documentation. The provider documents blindness, but doesn't specify whether it's one eye, both eyes, or which eye. And here's the rule: we never assume laterality. If the documentation doesn't tell us which eye is affected, we must default to H54.7, unspecified visual loss. This isn't a failure, it's accuracy. Coding reflects what is known, not what we wish we knew. Now we move into Chapter 9, where things get more interconnected. The patient has hypertension, congestive heart failure, grade 1 diastolic dysfunction, stage 3B chronic kidney disease. This is where combination codes shine. We start with I13.0, hypertensive heart and chronic kidney disease with heart failure in CKD stage 1 to 4. But that's not enough. Combination codes give us the framework, but we still need to define the specifics. I50.9 for the heart failure. I51.89 for other ill-defined heart disease. N18.32 for CKD stage 3B. Together, these codes paint the full clinical picture. Here we have a patient admitted with an acute myocardial infarction. 3 days later, still during the same admission, the patient suffers another MI, this time an anterolateral STEMI. The guideline is straightforward: any MI occurring within 4 weeks of an initial MI is coded as a subsequent MI. So we assign first I21.9 for the initial MI, followed by I22.0 for the subsequent anterolateral STEMI. These two codes must be paired together to show the sequence of events. In this scenario, the patient had a non-traumatic intracranial hemorrhage 1 month ago. Now they present with monoplegia of the right arm. The acute event is over. What we're seeing now is a residual deficit, a sequela. So we assign I69.321, monoplegia of the right upper limb following non-traumatic intracranial hemorrhage. This code tells the story. The stroke happened, it's resolved, and the patient is now dealing with the long-term effects. This slide compares the two systems we've been working with. For the eye, precision is everything: laterality, type, stage. Never assume sides and code separately when the eyes differ. For the heart, it's all about relationships, hypertension, CKD, heart failure, and understanding how they interact. Combination codes come first, and then we add detail to define severity. In both systems, documentation is the map, and the guidelines are the compass. And finally, the big takeaway. Accurate coding is detective work. We follow the clues in the documentation, we apply the guidelines, and we never fill in gaps with assumptions. Timelines matter. Specificity matters. Residual conditions matter. And when documentation is incomplete, we use unspecified, because that's the truth of the record. Coding is the bridge between clinical care and data integrity, and when we do it well, we support better outcomes, cleaner claims, and clearer communication. Thank you so much for joining me for this walkthrough. I hope these scenarios help you feel more confident applying ICD-10-CM guidelines in real-world ophthalmology and circulatory cases. I'll see you in the next episode.